So before ending, I will introduce Dr. Milind Desai and then I will hand over the mic to Dr. Milind Desai. Dr. Milind Desai passed MBBS from Goa Medical College in 2003, followed by MD in 2007. Dr. Desai was a Goa State Merit List holder. He hails from twin town of Savarde, Kulcharan in Goa and completed his education in Guardian Angel High School. In his quest to learn the best in the world, he migrated to London and after passing PLAB exam got registered in General Medical Council UK. He passed prestigious MRCP UK in 2011. He has worked in various hospitals in UK in his career spanning 20 years. He has worked as fellow in prestigious Glenfield Hospital, Leicester, UK, which is a world-class center in cardiology and respiratory medicine. He has worked as consultant at Royal Stoke Hospital, Stoke-on-Trent, England. He is currently working as senior consultant in general internal medicine with special interest in cardiorespiratory medicine and diabetes. He is director and founder of DMRC, Desai Medical and Research Center, Margao. He is founder, medical director and owner of Imperial Plus Hospital, Margao, Goa, which is a super specialty hospital with ICU. He is very active in conducting medical camps like cardiac camps with free ECG and echo and stress tests in various parts of Goa, especially in rural areas and villages of Goa. He has started echocardiography service in Savarde, Kulcharan to cater to the needs of patients from rural areas. Dr. Desai is associated with various national and international bodies as follows: Fellow of Royal College of Physicians of Edinburgh, FRCP Edinburgh, Fellow of American College of Chest Physicians, FCCP, Member of American College of Cardiology, Life Member of Indian Academy of Echocardiography, Member of Royal College of Physicians of UK. Dr. Milind Desai is an examiner for prestigious MRCP UK exams and regional advisor for Royal College of Edinburgh Physicians for Western India, Mumbai, Maharashtra, Goa and Gujarat. So I once again thank Dr. Milind Desai and hand over the mic to him to kindly train us. Thank you very much.
So good morning everyone. First of all, let me just explain how are we going ahead with this workshop. So let it be very interactive because there's no point, I have like about 1,000 slides, I can just present and probably just go and then it's not going to be helpful because as I'm presenting, things look very rosy, nice, yes, I know everything. But when you go home or after a few days, you tend to forget. When you say you, including me, we all have gone through that. So let's, this is for you all. So just interrupt me, stop me at any time and then we can always talk about, I want many questions, not at the end. At the end you can, but as we are talking, it's preferable. And after an hour or so, we will have a small break and then we'll get two patients, one for the heart examination and one for the lungs examination. And I'll teach you all how we do as one of your colleagues. So we will, the Hutchison's, which is a manual of clinical medicine, that's what we have learned our medicine, and this is all over the world. I've spent about 12 years in Europe, including UK and some years in US. They all follow the same thing. So what we will do is, we will go through systematically how to examine heart and lungs during the break from the ECG. Okay? So this is just a bit of humor, and this is in fact probably true because before the ECG was done, I mean like many years ago, before the ECG was invented, probably they were trying to just make sense by listening to the chest and things like that. Now this is just people who are very much interested. You can just note this down. And if you all want these PPTs, I can share it to madam and then you can have it. So no need to, if you want to jot down, you can jot down, but I'll make it available for all of you all. So this is how the ECG was invented. The reason we are telling this is there are too many ECG machines now. In fact, I don't know, some iPhones and the Apple Watch can give you ECG, and it is fairly accurate. So we have gone from bulky machines, and we have brought one machine with us. I will show you all. And there are different machines wherein, in fact, you can even get the ECG with the report directly. So we'll skip this. So this was actually how the ECG was done before. Because end of the day, what is the full form of ECG? Yeah. So it is electrocardiogram. Means electro means electricity, cardio means heart, and gram means recording. So it is recording the electrical activity of the heart. So end of the day, electrical activity means you need some kind of conduction, like how the electricity is conducted. Electricity is conducted. I can use this also, no?
Yes.
Hello? Can you hear me?
Yes.
So electricity is conducted. Electricity is, I don't think this works.
Let's switch that on.
This, I'll stick to this one. No problem. If this is off, I can spend more time here. Hello? Hello, yeah. So if somebody can volunteer for changing slide, just because it will be easier for me to stand here and explain. So this is how the ECGs were recorded, and this is true. This is because why I'm telling you this, to understand. End of the day, ECG is a electrical recording. You can't see the heart. Like I will probably next time show you all, if you come to my hospital, how the heart looks on an echo. And this is just the lines which are up and down. So this is how it was recorded. Next slide. So nowadays we have these machines. Now what we have brought here with us to show you all is exactly this. Wherein we put electrodes on the chest, and it's important where to put electrodes, and you get a recording. Now the recording can be a full page like a laptop, it can be a small strip, that depends on you. And nowadays what happens is, like our machines, we do an ECG, the ECG comes to me on my phone, wherever I am. And I can report. A couple of years ago, I had gone for 1 month in London, and I was actually working from there to my hospital. Everything was getting automatically transferred to me. So that is called tele-reporting. Next. So basically, we will not spend a lot of time. See, if we talk a lot about theory, how the impulse is created, how the waves are forming, that becomes a research theoretical presentation, which is going to take a lot of time. People who are really interested in lot of theory and that kind of a non-practical approach, will have to arrange that later, because it is quite complicated to see how the current flows in the heart, and then that has no connection with your day-to-day patients. So what do we do? Why do we do that? But for research purpose, at a later stage, we will talk about that. So this presentation will be mostly clinical. How to do ECG, how to interpret ECG, and how it will help you all as young doctors and students to manage your patients. Because there could be lots of never-ending discussions on what the ECG actually shows, and a lot of complicated discussions which even for us, we say, come on, why are we discussing all this? How it is helping me in treating my patient? Unless I'm doing research, like I'm doing PhD in a particular field. Okay? So next slide. Okay, so this is important. Why do we do ECG? Can anybody tell me most common reason? Just, yeah, why? What do we want to rule out or diagnose? Cardiac? IHD. So most common cause of people dying in our country is heart attack. And it's said that the incidence is increasing probably because of our lifestyle, wherein Ayurveda can have a big role, much more than what we have in allopathy, because we do prevention, but we ignore prevention, I have to admit it. So IHD, heart attack.
Okay? The first, what it's written on the slide is arrhythmias. Arrhythmias is any irregular heartbeats. Okay? Then myocardial ischemia and infarction means heart attack. Pericarditis. Some people have got hypertrophy. Their heart is big in size. That you can identify on ECG. Then very common. If there are calcium is low, calcium is high, sodium is low, sodium is high, potassium is low, potassium is high, magnesium is low, magnesium is high, and many other electrolytes. Anything happening in the blood will be reflected in the heart. So, and the reason why this is important, some of these problems can cause cardiac arrest. So if somebody is having potassium of 8, you can make out easily on ECG. You have not done the electrolytes. Patient comes to you, you will see a tall T wave, very tall. You know this is hyperkalemia. You have sent the blood, report is awaited, but don't wait for the report, because if you wait for the report, this patient can have a cardiac arrest and die. So before that you can treat. Yeah. Then last but not the least, there are many medications which we give. So there are many conditions wherein we have people taking anti-psychiatry medications, lots of other medications. Sometimes even medications given for heart, they themselves can cause. So sometimes the medications which are given for the heart, even they themselves can cause problems. So it's very important to do an ECG. It's not about just heart attacks. You get lot of information. Okay. So any questions on this? So you have to know ECG is done for different conditions. Most important, remember heart attack. So end of the day, after this workshop, if you all forget everything else, but if you know about how to diagnose a heart attack or how to diagnose a patient who can die, that's more than enough. Later step we can learn other things. Okay? So this concept you have to know, even though a lot of theory I said is for academic purpose, but this you can write down if you want. You have to know depolarization. Okay, so polarization means the heart cells, they have electric current. So our body, they say nowadays, I read a lot about quantum mechanics and other things. So where was that? Okay, so lot of theory you don't have to remember. Always remember, they say, especially in Ayurveda, that there is some aura, there is an energy outside our body, aura, like sadhus and all, they should always put like a behind the head, that aura, you know, like a moon or sun kind of thing. That's actually true, because every heart muscle has got a certain electrical energy. And when that energy fluctuates, you get fluctuations in the graph. That is called depolarization. Atria, anything contracts has to relax, right? So atria has contracted, but I have missed it. Mistake? So where is that? Huh? It is hidden in the QRS. Yeah, exactly. So the timing of it is with the ventricular contraction. So it is probably there. You can't see it because it is overlapping with QRS. The QRS is so big, it's hidden. But this is just for theory. You don't have to dwell more into it. Next slide. Yeah. Okay. So now, when we are talking about ECG, we talk about a duration. Okay, this is important because the heart, the impulse goes from a particular place to a particular place to a particular place. So we need to know what is the duration of the impulse, and we also need to know the voltage, how strong the heart is pumping. So that is in terms of the voltage. So in ECG, you need time and voltage. Time is in milliseconds and voltage is in millivolts. Just remember that. This is important because we'll be talking about different conditions wherein we need to know this particular timing and the voltage. Next. So the time, rather than calling time, we call it an interval, right? So PR interval is important. The time taken from P wave to QRS complex is PR interval. Very simple. Okay? Next. Next. So that is the time taken for atria to contract. Yeah? This is important because there are certain conditions wherein this PR interval is prolonged and there is a name for it and there is a condition for it and there is a treatment for it. That's why we need to know. So whatever I am talking theory is a applied theory. There could be lot more theory which even I don't understand, but that's for research people. So why do we have to know it at this stage? We need to know theory which we can apply. Next. Okay, next. Yeah, so let's just, if you remember this particular diagram, your half of your work is done of a normal ECG. So a normal ECG consists of a P wave which is very small but it is discernible, means you can actually see it. It goes up and down, you don't have to struggle to see it, though it is small, you can very well clearly see it. That's a P wave. That's the first wave in an ECG. And why do we get P wave? Because of what contraction? Atrial contraction. After P wave, you don't immediately get QRS complex because everything is aram se, slowly. Yeah, you don't have tea and lunch and dinner together. Between the tea and lunch, there's a break. So there is a small milliseconds of a gap between the atrial contraction and ventricular contraction. That is a PR interval. Okay? Then if you look at the QRS segment, the Q wave is very small, right? So this is the Q wave. Yeah? You can see it clearly, right? The Q wave is very, very small. A small Q wave is normal. A big Q wave is not normal. Just remember that. Okay? A small Q wave is normal. You all get it. A big Q wave is not normal. It is a sign of either recent or old heart attack. Then you get an R wave. R wave is an upwards wave. Remember R, right, up, and S is down. It's just a convention. Q is a first wave in the QRS complex. Just remember that. The first wave is Q wave, but it's always down. But if it is a small, then it is taken as non-specific. If it is a big, then there is a problem. What problem we'll talk? R is always up because right is up. Remember that way. And S is following R, so it is down. That is in a normal ECG. Now in an abnormal ECG, everything will be, R will be down, Q will be big, and those are the pathologists. We'll talk about it. Now we are talking only about normal ECG. If you are able to confidently say this ECG is normal, 90% done. You're done. At least you can tell the patient your ECG is normal, go home. The second step comes whether it is not normal. If you know this is not normal, I don't know what it is, but this is not normal, still you are a good doctor. Because at least you are telling this ECG is not normal, go to a senior doctor, do echo, do whatever. But if you are able to say confidently, this is normal, I am sure about it. And you might take 1 hour, doesn't matter. That 1 hour will become half an hour. Half an hour will become 15 minutes. Now we report, you can ask our nurses and this, like we report literally it takes us less than 1 second. So I see ECG normal. Not that I am super smart. We see ECGs, I see normal. Literally less than 1 second I report ECG. Because my brain and my eyes are tuned to it. And I have developed my ways, like algorithm in my brain. So you might take half an hour. After practice, 15 minutes, 10 minutes, 5 minutes, 1 minute, 30 seconds, 10 seconds. Now Shivani can report ECGs, right Shivani? Within 10 seconds? Yeah. I trained her. I mean, she was already trained. I refined her. Okay? So No, this is a practical. If you don't believe me, ask her. She is from Ponda on Eva. Okay? So, it's not tough. Everybody can become expert in ECGs. And your time of reporting will become substantially less. And even if you are able to say, this is normal ECG, I am 100% sure, done, then you are ECG expert. Because the ECGs which are not normal, yeah, even we sometimes argue between us. I will say, no, this is this, and Dr. Rajesh will say, no, this is not that. So we only discuss and argue. We have a group, we discuss complex ECGs. So, if you are able to say normal ECG, this is how it looks like. If the ECG looks like this, it's normal. And 90% ECGs will look like this. So take a photo of this in your brain, not on your phone. And if the ECG looks like this, done. Okay, so after QRS, there is a T wave. But always the impulses take little time. So they take little time, that is called ST segment. Now this ST segment is extremely important because that means ST segment down or up means death. Not down. Down is okay, blockage. If ST segment is up, that means you will die. 100% you will die. Unless you are extremely lucky and the nature heals you on its own, which happens, or you go to immediately you are thrombolized or urgent angioplasty. If ST is elevated, anywhere in the world, any country, any place, ST is elevated means you have to see a doctor. It's a medical emergency. Okay? Remember that. That's why ST segment is so important. Now, when the ST segment is elevated, is it really elevated or not elevated? Sometimes it looks like elevated. That is called reporting ECG. Otherwise, everybody will make, you say, your ST is elevated, emergency. So actually he is not, he is fine, but listening to you only will become patient and his BP will shoot up. So that happens. So in the, I don't want to criticize, but in some of the centers, they say, ECG sarcoma. Patient is there only half stressed. And they don't tell sarcoma. They come to us, I say, no, it's fine. But I don't criticize those doctors. They have not been trained. So unfortunately. And the training of ECG has to happen systematically. Okay, so nobody, even I am not 100% expert in ECG. There will be some ECGs I am not sure. That's not our problem because those ECGs are 0.0001%. Our main aim is this ECG normal? Can this patient go home safely or not? If it is abnormal, is it seriously abnormal, needing patient to get admitted, or it is abnormal but see a doctor tomorrow or day after tomorrow, get an echo done. If you are able to differentiate these three, that's enough. So remember that. Next. Everybody's taken that picture?
Yes.
So there are some ECGs which you cannot ignore. That ECG is telling you, giving you, it's like sign from God. Look, I have put this patient in your hand. He will die. You are his savior. And if you don't act and listen to that signal from God, you are probably not a good doctor. Probably I said, because we all do mistakes. So ECG, some ECGs tell you that look, this patient is dying. Do something. Do something. Now the problem is there are some patients who are actually not well. So even though ECG you don't know, you can see that they are not well. They are breathless. So you will obviously admit them. There are some ECGs where the patient is smiling, laughing and telling you I am fine, kinda. But that ECG is showing that something will happen soon. And then you go on how the patient looks. Distant tasa nasta, right? Looks are deceptive. So you see, a patient is fine, ECG okay. No, that ECG is telling you this patient will die, literally, and this patient will die unless he's super lucky. So those ECGs, it will not come as hell like this. This is just a cartoon, but you have to know that that patient is asking you to help him. Next. This is little complicated, but don't worry about it. All the ECGs have a standard paper. And just remember, the ECG have got cubes, right? Squares. There are small squares and big squares. It's very easy. Big squares and small squares. Yeah? ECG, do we have an ECG this? ECG? Just circulate one ECG, no? Or what you do, no? एक volunteer has a ECG card.
So we'll do it in the later part, you said.
No, they will at least see this. It's okay, we'll do later. So this is how the ECG roll looks like. Okay, next. So, you just don't remember those milliseconds and seconds. It will be a little confusing. Just remember there is something called as small squares and big squares. Easy? A small square and a big square. And the small square has a certain voltage and certain time that will revise later. Next. Okay. So how to put the ECG leads? We will show you practical demo. So we can skip this. We'll actually put ECG leads and our nurses will show you how to put leads, what mistakes to avoid, and how to take a normal ECG. Okay, we can skip this. Yeah. Skip. Yeah, this is, we just put 4 leads, 2 on the legs, 2 on the arms. This is very simple. Anywhere you can put. Anywhere in the arms and legs you can put. Now the chest leads, you have to put in this position only. You cannot put wherever you want. It has to be this position, which we will show you on a patient. Okay? Next. Very rarely we have to put leads behind or on the right side. Normally we put where the heart is. Where is the heart, right or left? Left. So we put over the heart. But sometimes we purposely put on the right and at the back. For a different type of a right ventricular infarction or posterior wall infarction. Next. Okay, this is important. So the ECGs, the heart is here. Why are we putting leads on the legs? Anybody can tell me? Why are we putting leads on the legs for doing ECG? Reason? Anybody? See, remember, heart is just an organ of the body and it's a highly electrical organ. So we are measuring the, see, have you heard of earthing? There is earthing. Yeah? So it's exactly like that. We are actually measuring the electrical activity of the heart. So we have to measure the electrical activity to look at the heart. And is it better to, so suppose if you want to see something, would you just see from one angle or different angles? Yes. That is why this particular leads, each lead gives you certain information from their own point of view, different angles, and then you get all the information and then you make a report. That's why it's called a 12 lead ECG. You might have noted when you do monitoring, ambulance and all, they just put 3 leads and you get only one graph. That is emergency ECG. In fact, the principle on the Apple Watch works is 1 lead ECG it is. It is actually, your watch is taking ECG. How? Nothing is near the heart, but the impulses of the heart are being sensed by this watch. But it will give you only 1 lead ECG, which is only used for atrial fibrillation. And that watch is so good that the data goes to the doctor. So the doctor will say, oh, okay, Mr. XYZ, you are having high heart rate, please come to hospital. Because the doctor gets a notification that patient is not well. In fact, even we have those watches in our clinic, right? We have given to some patients. So we also have those ECGs wherein you put your finger and you get ECG. If somebody is interested, we can give that to them. Ashray, you can give, the best student who answers all the questions will get that machine. Yeah, so you put your finger on that, just a finger, and you get ECG. on your phone. So this why these are important is, so it's a 12 lead ECG. Okay, there are 12 leads. The names are 1, 2, 3, as in 1, 2, 3. V1, V2, V3, V4, V5, V6, because we are putting on the chest. V means ventricle. Yeah. So V1, V2, V3, V4, V5, V6. And sometimes we put V7, V8, and sometimes we put on the right. So forget those. And there are 3 more you can see: A, V, R, A, V, L, A, V, F. So this is the quiz now. What does A stand for? You have to raise your hand. So whoever answers the most will get that ECG machine. A means what?
Augmented.
Exactly. A is augmented. So we are taking the normal impulse, and A is an augmented, like little bit of a higher voltage. Now why is this important? Because when it comes to these leads, one lead doesn't mean anything. It's a group. Yeah. So next. So each set of leads will tell you information about one particular anatomical part of the heart. Okay. So V1 and V2 will tell you a lot of information about the septum of the LV. Next. The V3 and V4 will tell you a lot of information about the anterior wall of the heart. So if you see an ECG wherein V1, V2, V3, V4 are abnormal, you know that there is something wrong with the anterior wall and septum. It's that way. Because the blockages in the heart, later on we'll discuss, there are 3 different coronary arteries. So you can't get blockages in all at one time. You'll get a blockage in one particular artery. So only those leads will look abnormal. Next, V5 and V6 and 1 and AVL, these 4 are together and they tell us about the lateral part of the heart. It's very easy. We put V5, V6 here, this is lateral. Okay? That's how you remember. V3, V4 we put here, this is the anterior part of the heart. Now, next. Now, 2, 3 and AVF, they tell us about the inferior wall of the heart from down. That's how it is. Why and how? That's how the electrical circuitry of the heart is. Again, if you really want to know, you can call me and we can discuss. It will require 2-3 hours of explaining how the impulses travel from how and how it gives that particular leads. There's a lot of thing about axis, right axis, left axis and all that. More of a theory, practically absolutely not required. But if anybody is interested, you can contact me. Next. So this picture you take, this is very important. Because you get an ECG and you say 2-3 AVF is looking abnormal, ST elevation. You know that this patient is having inferior wall, ST elevation MI, has to go to hospital. Thrombolysis. Call your 108 van, they will thrombolize. Yeah, if you want, you can send to us. We will take care. Best is to call 108 and let them do the job because they are trained. Okay. So you can just everybody can just go through this ECG. Let's see, it's normal. Next. Okay. Now I will just teach you all 10 rules, which will help you in diagnosing a normal ECG. Abnormal ECG is something which will carry on. Okay, remember these 10 rules. Okay, if you know these 10 rules, you can confidently tell about normal ECG. Rule number 1. Next. Okay, the rule number 1 is look at the PR interval. The PR interval should be 3 to 5 small squares. Okay. The PR interval should be 3 to 5 small squares. If it is 3 to 5 small squares, PR interval is normal. Rule number 1 is done. Good. 10% work is done. Now, when you know that PR interval is normal, common sense, you will want to know what if PR interval is more than what it is abnormal. What is that abnormality? It's called first degree heart block. So, when you know one rule and one particular normal thing, you know what is extreme of that. What is a very short PR interval? It is called pre-excitation syndrome or whole Parkinson's-White syndrome. Again, even if you don't remember that, forget it. But you know the normal PR is 3 to 5 small squares of the ECG. If it is more also, it is not normal ECG. Less also, it is not normal ECG. Done. So if it is more, it's one pathological condition called first degree heart block. If it is less, then it is another pathological condition which is called pre-excitation syndrome. Like a shortcut it is. Yeah, so if the interval is short, means impulse is traveling super fast. Yeah, so it is hyper, it's an excited, we say, why are you hyper today? We say, right? So it's a pre-excited, that heart is pre-excited. And if it is, interval is more, means I said traffic jam, right? Everything is slow. So it's a block. So it's called first degree heart block. So everything what I am talking is, from this to everything is related. Yeah. So first rule. Everybody is clear about this first rule, because I feel if you know these 10 rules, you will be fine. Because these 10 rules are the basics for you to understand normal ECG. And when you know these 10 rules, you know any deviations to these 10 rules means a pathological condition. So as simple as that. So less PR interval is some condition, more PR interval is one condition. Okay? Yes. Second rule. Yeah. Now the QRS complex should not be too narrow or too wide. It should be only 3 small squares. Okay, so you measure the QRS and see whether it is fitting in 3 small squares. If it is fitting in 3 small squares, your QRS is good, normal. If it is taking 5 small squares, means it is broad. So again, broad QRS means what? There are lots of conditions. It could be a bundle branch block, it could be ventricular rhythm, lot of things are there that we can study later. Okay, rule number 3. Okay. Now in 1 and 2, lead 1 and 2, the QRS complex should be up. Can you make out on the ECG up and down? Look at the AVR, AVL, AVF here. So this is down and this is up. Yeah. Now, unfortunately, they will not be always totally up or totally down. Sometimes it will be 80% up and 20% down. That should be taken as up. So we are talking about predominantly. So in lead 1 and 2, the QRX should be dominantly up. If it is not up, which condition, who can tell me? It's a rare condition wherein this rule will go wrong. In lead 1 and 2, QRS is down. Very rare condition. Who can tell? Very good. Dextrocardia. So if the heart is on the right side, this rule will be violated. Now if the lead 1 and 2 is down, you do an ECG, will you say you have got dextrocardia or will you do something else? Huh? Yes. Just check whether you have done any mistake in doing ECG. Most common is they have done a mistake. Yeah, because how common is dextrocardia? Extremely rare. So when you are making a rare diagnosis, common things common. If ECG is not moving proper, just recheck whether it's done properly. Okay? The next rule. Rule number 4. Now, 1, 2, 3 and AVR, AVL and AVF. These are called limb leads. Okay? So 1, 2, 3, AVR, AVL, AVF are called limb leads. 1, 2 and 3 are standard limb leads and AVR, AVL, AVF are augmented limb leads. And the remaining are chest leads or precordial leads. Okay? So when, if the QRS and T should have the same direction in the 1, 2, 3 and AVR, AVL. What it is saying is, if the QRS is up your T should be also up. If the QRS is down, T should be down. Then it's okay. If the QRS is up and T is down, that means it's an abnormal ECG. Okay? These rules are made not to complicate you or confuse you, because if you go by normal conventional method of learning, it will take you years. So if you follow these rules, it becomes easier for you to confidently tell the normal to abnormal. Okay? Next. Right. Now always when you do ECG, look at AVR. Now we call AVR as an orphan lead. So when I was talking about the septum, anterior wall, inferior wall, lateral wall, did you all notice that AVR I didn't say anything, right? So AVR is not pointing to anywhere. So we used to call it long back orphan lead, but now it has become a super powerful lead, because in massive MI we have seen if there is a severe blockage, it becomes elevated AVR. But we will skip it for today's lecture. Look at AVR, it has to be down in all the ECGs. Doesn't matter. If it is up, then there could be two possibilities. Which are those two possibilities? Dextrocardia, or you have put left lead on the right and right on the left. So we put leads on the right arm and left arm. You have done a mistake of arms. That's the most common, and it happens. It happens very commonly. So I have told all my staff, before they take a print, to save paper, before they take a print, the ECG comes on the screen. If AVR is up, check the leads. Okay, remember this. Next. Okay. The rule number 6 is, in the chest leads, there is V1, V2, V3, V4, V5, V6. You know what is an R wave? Everybody knows what's an R wave? It's a upward wave, right? I said R is up. So the wave which goes up in the QRS complex is R. Now, in V1, there is a very small R wave. In V2, the R wave becomes little taller. And in V3, it becomes a more taller. V5, V4, V5, V6 is very tall. That's called R wave progression. Means the R wave, which is small in V1, becomes little bit taller in V2, V3, V4. So it increases. So the R wave, that's called a normal R wave progression. If you are getting a very tall R wave in V1, or the V1 there is a R wave, but V2, V3 is not getting bigger, it's remaining small only, we call it a poor R wave progression. Again, it's an abnormal ECG. So remember this rule. Next. Okay. Now this is the most important. The ST segment. Isoelectric means not down or not up, not depressed or not elevated. It's isoelectric, horizontal. It has to be in almost all the leads, except in V1. You ignore that V2. In V1, sometimes you get ST a bit elevated, but only in V1. Then you can ignore. Anywhere else if ST is elevated, you call your senior. That ST elevation has to be looked at as an emergency. Now, it may not be real emergency. The consultant might say, no, it is elevated, but I feel it's okay, based on my experience. But still, even though how much experience I have, I will always say, I think it's normal, but I'm not 100% sure. I keep the patient for observation. We do troponin. We repeat the ECG, and better to do echo also. And if echo is normal, repeat ECG is normal, and troponin is normal, then only patient goes home. We've had conditions wherein people have gone to this, and ECG they said slight ST elevation, but okay. And most of the patients, when they come to you, They come with a plan in their head. They have chest pain, yeah, but they make a plan. I'm going to go to doctor. Doctor will give me some painkillers and doctor will send me home. That is their plan. They have already diagnosed kind of acidity. But which is Rahobaya. So they come, you do ECG, you are a little worried. But patient wants to now have his diagnosis right. So now kind of acidity, gas khala, whatever, they'll give their own story and will hypnotize you. And you want to be nice to the patient. Nobody wants to give a bad news, right? You want to say, no, okay, kind of open, it's all positive thinking. But you know that ST is little elevated. Patient wants to hear, go home, all the patients. And patient goes and dies at home. This has happened hundreds of times. Hundreds of times, not this. So, ST elevated, you let the patient criticize you, give you bad words, not your problem. You say, look, you have to get admitted for observation. Otherwise, you take their undertaking. Don't be very nice to all the patients. In their own interest, I'm not saying like be harsh or talk rudely. People come with a plan. And if the patient dies, will the patient curse you? No. Patient has died. But you force them to get admitted. Now, 95% of these patients will have a normal troponin, nothing. But those 5% who are going to have a problem, no one can tell looking at the ECG alone. So this is something which I want you all to, when it comes to heart, or just take signature. Because ultimately they spoil your name. They will say what? They will reach somewhere and criticize you. But actually you have told to get admitted. So document it well. Next rule. Okay, the P waves are usually upright. But except in some leads. So see, in 1 and 2 and V2 to V6, that means in V1, if the P is inverted, it's okay. It's that way. Okay, this rule, some of the rules are straightforward and easy. Some you have to literally revise. Now even in your studies, some are straightforward. Some you have to do Pathantar. Like we used to do Pathantar. We used to keep on like reciting again and again and again. Yeah, there's no option. Like that, this you have to recite and get it in your brain. Next. 9th rule. Right. This I told you. Q waves are always abnormal. Okay? Unless they are very small. Very small means just maybe 1 or 2 small square. Now I'm going to avoid talking about millivolts. So the squares, if you look at the squares horizontally, x-axis, it tells you the time. And if you look at the squares vertically, it tells you the voltage. Yeah? So if the Q wave is down, but 1 or 2 small squares, it's okay. It's a small Q wave, taken as normal. But any big Q wave, you have to investigate further. Okay? Next. Last. The T wave should be always upright. Anywhere T wave is inverted, except we talked about AVR. AVR, everything is inverted. We have said that in one of our rules. So no need to talk about AVR, right? Okay? Now, coming to the chest slits. In V1, 95% patients will have T wave inverted. In V1. Now, T wave inversion means sign of ischemic heart disease. Okay? But only if there is T wave inversion in say V1, V2, V3, V4. If only V1, you cannot call it an IHD. Because if you do your own ECG, your T wave will be inverted for sure in V1, especially in females. That's how it is. It's natural. Okay, next. So, this is in a nutshell. Yeah, this is in a nutshell. If you know these 10 rules, you know the ECG well. Okay? Now, we will not talk much about P wave, because P wave is not that important clinically. Next. And it's easy. Next. Okay, I'll just talk about normally the P wave is like just one wave, okay? If the P wave looks like this, it's called biphasic P wave. Okay, it's called P mitrale. Rather than one P wave, like one mountain, it's like an M. So it's a biphasic. And that's a sign of left atrial enlargement. Okay, all this I will give it to you all. Next. If the P wave is very tall, big P wave, which condition commonly, who can tell me? See, normally the P wave is very small, maybe 2 small squares, not very big. So if the P wave is very big, common condition, who can tell? People who smoke, which condition you get? Which one? Yeah, in COPD, if you get a tall P wave, it is definitely COPD, no doubt about it. Okay, remember that. Next. Yeah, the short PR interval, it's a little complicated condition. Next. Yeah, we talk about long PR interval. Long PR interval is first degree heart block. Just remember that. Long PR interval means the impulse is traveling a little slowly. It's first degree heart block. Is it important? Not important. Forget about it. In most of the people, it doesn't cause any symptom. Okay? Second degree and third degree heart block is something you need to worry about. First degree heart block, just academic purpose. Next. 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 Go before. Yeah. So now the QRS complex, if there is a ventricular hypertrophy, do you know what is hypertrophy? Big. Yeah. Then the QRS complex will appear very big, very tall. And then there are certain criteria. Now we will do lots of normal ECGs here. If you keep on looking at the ECGs, see there is always in human beings, we all look different. Some are tall, some are short, some are fair, some are British, curly hair, straight hair. But we all are normal. But we don't all look normal. There is a certain criteria. Yeah, like that. All ECGs will not look normal. There will be something up or down. That's okay. So that's why there are certain criteria. So if you measure the height of the QRS, if it is more than 35 millimeters, we call it a left ventricular hypertrophy. If you are not sure, but in general, if the QRS complex is very tall, then you can assume that it is a hypertrophy. But if you are not sure, then you have to measure. One small square is 1 millimeter. Okay? So you calculate the, just count 1, 2, 3, 4, 5, 6, 7, 8. If it is more than 35, it is LVH. Just like that. Yeah? Next. So if more we talk, now mind gets saturated. So when it is saturated, please tell me. We'll take a break. Okay? Now, we talked about, okay, next. Yeah. See, look at common sense. This looks very deep or normal? Yeah. So deep, and this looks very tall or normal? So anything tall or deep means hypertrophy. Okay? Remember. Now, as I said, you have to actually measure. There are different criteria, which is not that important, I would say. Next. So yeah, this is the criteria. So you have to measure the S wave in V1 and R wave in V6. And if it is more than 35, that is a confirmation that it is LVH. That is a Sokolov-Lyon criteria. So this is one which we use commonly. You measure V1 and V6, and if it adds to 35, then you can definitely say it's LVH. Why this criteria made? I say this is normal. Madam Bali might say no, this is not normal, this is LVH. So we'll start fighting. So the criteria is there. 35 means yes, standard. If it is 35, it is so that because there is always a not like we always argue clinicians with each other. The aim is to give a best quality to the patient. So for these arguments, this criteria are there. Next, see look at that. You calculate. Who can calculate? Like I want one volunteer. We do it quickly. Any volunteer? Just come. Just come. Because it will give you that confidence. But you just come and calculate. Anybody. It's very easy. Wait, I'll call. Otherwise, you all will never come. So, yeah, you come. You've been very attentive. So she was nodding for everything. So. Come fast. We have less time. So what you have to do? You have to look at V1. Okay? Wait. You calculate this from here to here. Yeah? So see, these are 5 squares. 5, 10, 15, 20. These V1 and V6. You add and tell me how much is the and that. Go ahead. $55, right? So it is way above 35. So this is LVH. Done. Okay? Now give her an applause. Okay. Okay, this is very important. Now look at this carefully. So ST elevation means it's an emergency. Okay? Next. So look at this. These ST segments, 4 are there. Are they isoelectric or they are elevated? All are elevated. Okay? So why I have given 4 pictures is elevation may not be exactly how you have seen in one patient. There are different. So the first one, is called concave. The second one is called horizontal. The third one is also concave with a bit of a notch. And the fourth one is too much elevated, hyper elevated. Okay, this one. So all these 4, if you get these ECGs, this is patient will die unless you thrombolize or do an angioplasty. This is a ST segment elevation MI. I'll show you the actual ECG. Next. So now go back. So this you can take a picture. If you see ST segment elevated like this in any lead, you have to get worried. If you see ST segment elevated like this, these 4 different types are there. Okay? You should get worried. You should always consider that this is an acute MI and this is not something you admit and observe and do. No. This patient goes straight away to cath lab or we thrombolize if the cath lab is not closed or ICU. This patient is ICU. Because these patients can have a sudden cardiac death. Next. QT interval will skip. It's little non-important thing. Next. Okay, I'll just talk about U wave. Anybody has heard of U wave?
Yes.
Yeah. So any small wave coming after the T wave is called U wave. It's only important clinically in one condition. Which is that condition? You get U wave in which condition? Who can tell me the last person on the bench? Can you stand? Just stand. Yeah, any electrolyte abnormalities which can cause U wave? Yes, hypokalemia. So low potassium, very low potassium can cause a U wave. Okay. Next. Yeah, now determining the heart rate, what you have to do is, nowadays everything is written on the this computer, on the ECG. So this is outdated, not required, we'll skip it. You get the heart rate on the ECG. Next. 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 Okay, wait now. What is this? What is this ECG like? It is tachycardia. It is fast. But this is a. What is this ECG? Anybody can tell? It's obviously it's not a normal ECG. But this ECG patient can get cardiac arrest anytime. So this is ECG of ventricular tachycardia, VT. This patient you have to shock immediately. Even before we take to cath, this patient needs to be shocked. Shocking means we put one electrode here, one here, connect to a AED machine. You don't have to do anything. Next time we can get, you all have AED here. I will get one AED portable. Yeah, you keep it, because if you put this to the patient, it will tell shock not required, or it will say shock required, shocking, and it will automatically shock, and that will save the patient. It's called automated external defibrillator. I think we should have it because you all get lots of patients, and we don't know, they might have a problem, you don't know. So put that, and automatically it will sense. Let me know. I mean, if you want, we can donate. I have got some tie-ups. I have kept in my hospital and clinic. And in fact, I had written to the CM that it should be put in everywhere, bus stand and railway station and airport. Anybody can use it. Normal person. Instructions are written. One patch is there. Put here, and press the button. It's automated software is there. It will either say shock not required. Means what? Take it out and you do what you want to do, take to ambulance and all that. If shock is required, it will automatically shock, and that means life and death. Because the only treatment for VT is shock. Nothing can save you. You either die or you survive. Because if it stops on its own, you will survive. It's called a non-sustained VT. If it is sustained VT, patient will die for sure unless shocked. There is no other way out. Okay? You must have seen, right, previously, like people like in the movies and all, they put those pedals and they shock. Nowadays that's gone. Because would you be, what if you get shocked? Yeah, you don't, but people are scared. Especially not the doctors, the other people. So this is automated AED. Madam, if you want, you tell me. I'll donate one for you all. I have. Okay, you let me know. Because it's an institute, no? I cannot just give. It has to be proper written and permission and all. Next. 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 Keep skipping. I'll tell you to stop. Wait. Now, talking about the axis, you have heard of right axis deviation and left axis deviation. Just skip it because that's very complicated and it is not helpful in clinical practice. And whatever you have learned, you will forget that and you will put axis in your mind, which is the least important and most complicated to understand. So I would avoid it because clinically it's not important. Okay? Right axis deviation and left axis deviation, it's not important. So in this ECG, I'll ask one of the volunteers. Okay. Yeah, you stood up, no? Yeah, last girl. Yeah, please come. Come faster. We have less time. In 5 minutes we'll take a break now. So you tell me here the T waves, they are normal, upright or inverted? T wave. Huh? Okay, look here. Okay, then.
V2, V3 it is inverted.
Yes, that's enough. So it is normal or abnormal?
Abnormal.
Yes. So done. V2, V3 T wave is inverted. It is abnormal. So she has diagnosed it. Now why it is inverted reason? Most important cause of T inversion is ischemic heart disease. Okay? So ST segment depressed or T wave inverted means it is IHD. Now this patient needs to go to a doctor. Maybe echo, angiography, whatever. It is still an emergency. But ST segment elevation is life and death. Okay? Very good. Next. So this is just, now this is a basic rules. There are about 30 more presentations, 30. So I think we'll take a break and go for clinical examination and then I'll show you.
Yes.
About the heart attack ACS. Yeah, okay.
10 minutes break.